Guys, we're still waiting a little bit, but thanks for joining in.
Hey, good morning, everybody.
Morning, how are you?
I'm all right. How are you?
I'm good. Sorry, just playing some music here.
No problem. No problem at all.
We still have around 3 more minutes, so I would let a few more people join in, if that's okay. I think you muted yourself. I can't hear you, but I can.
Yeah, sorry.
Okay.
Yes.
Awesome. Yeah. So we'll still just give people 2 more minutes here, and then we'll get.
Meanwhile, let me share my screen and make sure that that sharing is going well.
Okay.
So, are you able to see my screen?
Yes.
Okay. Awesome. Yeah. So let me make sure this is the new changed version, because I slightly added them.
Awesome.
1 or 2 things because of the audience group. I want to, yeah, I think this is the right one. I'm on the right PowerPoint, so be good.
Awesome. Thanks, Dr. Maddu.
Yeah.
One thing is, I usually record this for people who cannot be able to join in. Is that okay?
Totally fine. Totally fine.
Okay, so everyone, karibu, karibu. I hope everyone is doing great. And the people who had some good news this week, last week, because of USMLE results,
Oh, great.
congratulations. Um, so today we have Dr. Kiran Maddu, who is one of our colleagues here at Emory University, and he specializes in emergency and trauma imaging. He'll tell us his story. I usually like to afford that to the speaker, but I'm super, super excited to have him here, and hopefully he'll be back. But talking about the emergency room radiology. This is a general lecture, so just to help you understand. And please, I know there's always mute, but if you put the questions in the Q&A or the chat, I can pass them on to Dr. Maddu, and we can all learn from this. So thanks for joining. Hope everyone is doing okay, and take the floor, Dr. Maddu, and please spend a little more time talking about yourself before we
Sure.
yeah.
um, Good morning, everyone. Maybe good evening for you. And yes, thank you so much for the opportunity. And I'm so much pleased, delighted, as well as honored too. So to talk about myself, I'm from my residency is from India, and from there I worked as a faculty in India for 3-4 years, and then I moved to Tanzania and worked as a consultant radiologist there for 3 years, from 2007 to 2010. That's where I took my USMLE exams, and then I applied for fellowships here, and I'm a product of alternate pathway. I started my pediatric radiology fellowship at the University of Michigan, Ann Arbor, and then I moved to Emory for abdominal and interventional radiology fellowship in 2011. And from there, I did like 4 different fellowships, and 2 of them are emergency radiologists, and that's one of the reasons why I opted for emergency radiology. That was my last fellowship as also emergency radiology, and meanwhile I did one body MRI fellowship. That's briefly about my training. And then I took my board exams in 2014 and board certification in 2015, and I joined as a faculty in 2015. So this is my 5th year as faculty here at Emory. It's a wonderful place to learn radiology and explore the research, the teaching, everything. And I'm so glad to connect with you all. And thanks, Judy and Dr. Newsom. So it's a great opportunity to include me in this teaching program, and I try to do my best. And um, I'll be in touch with Judy to like keep you posted, like when I'm available, when we should be able to do this. Okay, moving on. Today's my topic is I did not make any particular didactic today. Today I wanted to briefly talk about the emergency radiology, and the topic I chose is moments of Zen in emergency division radiology. So it will be more like a what exactly is the pleasure of being a radiologist, and specifically emergency radiology has its own beauty. That's one of the reasons why I took this as my one of my career options, and is as my career option. And one of the reasons is like the amount of uh, the amount of role we play in the management of a patient is phenomenal. So I just kept some examples there to make you understand how exactly I feel sitting in the room and making my job as my one of the joys I have in life. So is this a reality? So that's I'm just trying to move my Zoom screen a little bit here and there so that I see all my what exactly I wanted to teach you today is I'll be able to see everything what I'm saying or talking. So moments of Zen, is this real? So as far as the philosophy of Zen is considered, we all try to derive whatever we may be doing. It may be our jobs, or it may be our family life, it may be anything we do, our hobbies. We try to derive some pleasure in what exactly we do. So is a radiologist. First of all, we are, even before a radiologist, we all are doctors. So the first question which I have to answer as a radiologist is a radiologist a doctor? So the perceptions in India and abroad, first thing which I would say is the time is the time now for radiology is one of the brightest and most beautiful times. So I could see, I started my residency in 2001, and from then to now, I could see a lot of changes of perceptions of a radiologist himself towards the profession, as well as the public, how exactly they receive us. When I started in India, mostly India radiology is predominantly in those days ultrasound, and we used to do a lot of scans, and we used to interact a lot with patients. So sometimes I used to get some strange questions. Are you guys really a doctor? Are you just a trained technicians? So, and then I moved to Tanzania in 2007. So there I had like a different perception. Because I used to work for Aga Khan Hospital, and there's one of the beautiful and one of the most famous hospital in Tanzania, and that is the only center which had MRI in those days for the entire nation. So the feeling was totally different. Like, you know, the people were different. I used to speak a little bit of Swahili there and interact with people. And then slowly, in 2010, I came here. So in these three, comparing all these three areas, it became more and more connected to computers and less connected to patients. So that's one thing which really made me think about all these things. So when we imagine ourselves as medical students, we were thinking of patients, dealing with them, talking to them, consoling them when needed, and advising them properly. So how that part is managed, that I'll try to talk about in my lecture. So who is a doctor? It is all about healing. That part, if you look at the definition of a doctor in medical dictionaries or the regular Merriam-Webster dictionaries, it's all about healing. So you have to understand that the role of your personality or your work or your profession and your knowledge, it may be medical knowledge or radiological knowledge, in the process of healing, how far is your helping? And coming to the word Zen, it came from the Sanskrit word dhyana, which migrated from India to China and then to Japan, and then it became the Zen. So it's a state of calm attentiveness in which one's actions are guided by intuition rather than by conscious effort or rational reasoning. So to understand this statement, by overall appearance, it sometimes everything cannot be having a rational reasoning. Sometimes the patient even doesn't know who made the exact or a right diagnosis, but it's your clinician who understands your dictation, or when you communicate with them, they understand the significance of your communication. So for most of the radiologist part, this kind of attentiveness or this kind of intuition, it should come from you. That's one thing which I realized as I'm growing older. And well, who gives these moments to you? Let's see, I'll show you like at least 6 or 7 scenarios, and you have to identify the entire objective of this lecture is to understand the significance of a radiologist in the management. So overall, the introduction to emergency radiology, one thing which I would like to tell you is if you look at this chart where we have seen the importance of emergency radiology over the past 2004 to 2016, if you look at the blue line, the ED visits, they are gradually increasing in quantity, and as well as the utilization of the CT in the Medicare patients. If you look at the graph, it is phenomenally increasing. So that shows the growing importance of imaging in the emergency radiology. So the rate of use of CT grew over 153%. Even though we are trying to talk about radiation exposure and all those things, but it is in emergency. What happens is it is the situation of the patient and the situation of the clinical presentation and the clinician's decisions which make most of the imaging which necessitates the imaging. So that's why it looks like the trend will be growing. The thing which I'm trying to tell you is the trend will be growing. So we have to understand how exactly it's working. So in AD in US, most of the radiologists, it is only the radiologists who interpret almost all ED/CT examinations. And to tell about my division, we work 24/7. And our night shifts start around like 10 o'clock in the night and 7 o'clock in the morning. We have 2 residents with us, and we try to manage at least like 4 hospitals and then 1 or 2 additional consults from other hospitals. It's a busy shift, but it's a very rewarding and a very inspiring shift to work in. Reasons for increased utilization are technological advances in the CT technology. We have moved from some of the situations may be more applicable in India or in Kenya. We may be doing still some ultrasounds for some of the cases like appendicitis. For here, what I observed is mostly it is diagnosed in CTs, and most of the ED problems, the CT helps you a lot. And we have an availability of 24-hour CT coverage. If somebody is trying to work or develop a emergency division in your own places, the 24-hour CT coverage becomes a very key in developing a division. And the lack of a pre-authorization requirement for CT in the ED, this is one of the things which we may have to work a little bit because sometimes we are misutilizing our resources. That also I'll talk at the end of the lecture very briefly. And the fear of malpractice liability is a little bit higher in these communities. That's one of the reasons why the CT or any imaging is inadvertently used. And availability of overnight coverage by radiologists is another option why we are using more and more imaging nowadays. So today, in today's lecture, I will talk about the role of a radiologist in a diagnosis and the management and how exactly you derive that moment of Zen for you. And we will talk about some case examples. I will try to be very slow when I'm describing my case so that you will understand what exactly the findings which I'm trying to show you. And at the end, I will also talk about overutilization and what are the initiatives we have to undertake. And I hope you all are able to see the images clearly. If anything is missing, just please let me know. Judy, are the images okay?
Yes, they're very okay. Yeah.
Sure. So I will give you a couple of seconds to take a look at those images. Coming to description of the images and findings, in the first image where you can see a lot of
if you want like for people to sometimes, I mean, we have quite a number of people, but if you want to give them like 1 minute to respond, that's also okay. But
nice. That's fine.
Yeah.
Okay.
So people can chat if they want to see. If you have a specific question, I can facilitate that. Like, what's the diagnosis, so something. But we can also go with the show and tell.
Okay. In the first and second images, I would like anybody to say what exactly I'm trying to show there. Anybody can talk about it.
They'll not be able to talk because because of the platform.
Okay, so in the first and second images here, I'm trying to show one. I can see somebody pancreas. Okay, not a bad thought, but if you look carefully, I'm trying to locate a tortuous vessels which are twisted on their own. So these are the tortuous venous and vascular structures which are twisted on their own. Yeah, that's a right answer. That's an appropriate answer from Abdul Latif. Nice. It is the twisted whirlpool sign, which the mesenteric vasculature is twisted. If you bring your attention to that, then you can observe the surrounding distended and radially oriented bowel loops, which are predominantly fluid filled. You can see significant amount of fluid filled bowel loops here. So in this image, I'm trying to show you again the dilated fluid filled bowel loops. Some of the bowel wall shows some amount of enhancement. I hope probably you know what exactly is an enhancement. When you give contrast, look at the iota here that says that this is a bright iota, bulb-like enhancing iota, tells you that this is a contrast examination. And in the contrast examination, you can definitely see some amount of enhancement. But if you come a little bit closer to the posterior aspect of here, you see a lot of fluid here. What exactly is going on with the fluid? And if you look at the bowel loops in the posterior aspect, they are totally different from these bowel loops. So what does this indicate? Can anybody guess? I'll be looking for the chat box. And this is the same image where exactly I showed you bowel obstruction. Some of the bowel loops are showing enhancement. Some of the bowel loops are edematous, fluid in the abdomen in the presence of a small bowel obstruction. And you can see bowel wall is hypo-enhancing or not enhancing properly, right? So this is the area where I want you to focus. These are the bowel loops which I want you to focus. Very good. So let me check your answers here. Why I'm not seeing, yeah, I'm seeing some. Yes, excellent. Excellent answers there. Ischemia and infarction. This is an excellent answer, I should say. So that's what exactly we talked about. We told the clinician, patient is 80-year-old or an old patient. We told them it is the mesenteric vasculature twisted on its own axis, which is called mesenteric volvulus. And we told them the bowel is obstructed. But most importantly, we have to communicate with them. Some of the bowel loops are not looking good. What does I mean not looking good? They are edematous, they are hypoenhancing, the vascularity is compromised, saying that, as Abdulatif mentioned here, it is ischemia and infarction, operative note, and the moment of Zen. So areas of ischemic bowel subsequently with evidence of good perfusion following a running of small bowel and the mesenteric detorsion. So this is the operative note which makes a radiologist, when you come next day and look at all your previous day positive cases, uh, that's where you derive the sense of satisfaction in your work. Hey, patient may not be knowing me, but I know, I look at my dictation and I know that how much I helped the surgeon to go in quickly, one thing. Second thing is, they need not resect any of the bowel loop because our diagnosis was on time. Make it a habit to check your surgeon or read the operative notes. Then you derive your moment of Zen. So here in first case, which I wanted to tell you is time is money. So if you can save that time for the patient, you saved resection of the small bowel loop. Imagine the same thing going on in a young patient. So briefly to talk about small bowel obstruction and radiology, still small bowel obstruction is one of the leading reasons of emergency visits. 16 to 18% of our cases are small bowel obstruction, and some patients are admitted, and some patients are turned into emergent surgery. For instance, the example which we discussed earlier. But mostly now, the important thing for a small bowel obstruction aspect and a radiology is clinical signs are not always specific to say that this is a bowel obstruction. And the management of the patient is always determined by the radiological findings, presence of any complication like ischemia or infarction. And treatment shift is nowadays towards non-operative management. So imagine how essential and how accurate your diagnosis of whether there are complications or not. So coming to the radiographs, which you always will be interested to look into these air fluid levels, but unfortunately, they're only 50 to 80% accurate in diagnosing, and most of the times you cannot say what exactly is the cause for obstruction. For example, look at a non-contrast. There is no contrast in this image. Still, I can show you some dilated bowel loops, the bowel obstruction, as well as I can show you a mass-like region here. Let me point out to you with my pen here. Look at this small bowel obstruction with a mass. So this is a turned out to be a small bowel adenocarcinoma. So if you can diagnose bowel obstruction, if you can tell the cause, it will be a very rewarding for you as well as the clinical team which is attending the patient. For example, this is another case where small bowel obstruction you can see, and you can see a telescoping of bowel loops one into the other. So can I expect some answers here? I'll wait for a couple of seconds to look at you can see I'll describe the findings and I expect some answers to pop in. I see the telescoping of bowel loops into the more distal form of bowel loops. Excellent answers there, Irene and Abdul Latif. Thank you so much for participating in this. And this is a classical case of intussusception, which is a very uncommon cause, but it needs a surgical intervention because it may go into ischemia as well. So the indications for surgery, which can be identified on CT imaging, will be volvulus, incarcerated hernia, intussusception, gallstone ileus, foreign body ingestion, and small bowel tumor. And talking about adhesions, because most common cause in this community for small bowel obstruction is small bowel adhesions, most likely due to prior bowel surgery, or sometimes occasionally even without no history of surgery, they can occur even a prior episode of peritonitis. But the key role of a radiologist is to talk about complications. And if you see a complication, communicate with the clinician. Most of the cases nowadays, the adhesions are treated with conservative management and they don't go for surgery. There's another interesting case, which is a small bowel obstruction. You can see the radial distribution of the bowel loops dilated, but the bowel loops showing a normal bowel wall enhancement. And if you look at the images more carefully, this is the bowel obstruction, which is showing some dilated bowel loops with a normal enhancement of the bowel wall. But below the pelvic line, you can see a small bowel segment entrapped within the obturator foramen. How do I know that it is an obturator foramen? If you look at the anatomy of the pelvis, you can see the pectineus muscle here, and you can see the obturator externus muscle here, obturator internus muscle here, and a small bowel is impacted. But of course, it is enhancing normally, so it's not a worrisome, but definitely this cannot be picked up clinically. It's not like an inguinal or a femoral hernia, which can be diagnosed clinically. This is an obturator hernia, which will be hidden in all clinical examinations. So those are the situations where the radiologist can do a brilliant job, and you can have the you can have the moment of Zen for yourself. And this is second case now, and I see some more answers here. Intussusception, very good. Okay, so and this is a 38-year-old female with a diffuse abdominal pain. So I leave a couple of seconds to you. I start describing. Meanwhile, if you can answer in the chat box what exactly is going on, that will be great. But this is a little bit tricky case because right now I did not reveal all the history to you. So patient comes with abdominal pain, right? And what I see here is, you can see the abnormally thick-walled bowel loops here, and mesenteric hyperemia, a lot of fluid in the abdomen. Yeah, that's good. That's I see some more answers, and then you can see the bowel wall edema here, and very edematous small bowel loops. I tried to show some asterisk mark there for the bowel wall edema, and a lot of fluid surrounding, but there is no signs of obstruction here. Still, I can entertain bowel ischemia. I did not give you any history, but the first thing that comes to my mind is enteritis, bowel wall contusion, and hypoproteinemia can also have the bowel wall edema and ascites. Bowel ischemia, as that one, I see that answer coming there, and in the chat box, I can see infection. Yeah, I can see. So yeah, So we were just moving, come from a case of classical proven ischemia. So we all get tempted to diagnose another case of ischemia, but here I draw your attention to the a rare condition, angioedema of the small bowel. So the patient, the history is she recently started ACE inhibitors. In our case, she started lisinopril. So the moment you know the history, it's totally changes the course of the event and course of the diagnosis. And what exactly is this angioedema? The clinical history is very important. Sometimes it can be hereditary and acquired. C1 esterase inhibitor deficiency, some drugs, like in our case. I have seen one or two cases recently with food presenting with a small bowel angioedema, but which I diagnosed as enteritis. But after talking to the clinician, my diagnosis changes because the presentation is mostly related to abdominal pain rather than any diarrhea. Angioedema may be idiopathic also, but I have not encountered any case so far. It's most commonly involves the jejunum. Intestinal angioedema typically subsides in 12 to 24 hours. Removing the inciting agent usually leads to complete resolution. So this is one area where I would tell that where exactly you become, apart from a radiologist, you become a primary care physician or an internal medicine doctor, like where exactly knowledge plays a very critical role. And this moving on, this is a 27-year-old female with acute diffuse abdominal pain, tachycardia, blood pressure is 100/70. You can understand from these two areas what I'm trying to tell you, that the patient is in a little bit kind of shock, rigid lower abdomen, and then pregnancy is excluded, or the pregnancy test was negative. So I was trying to show you the Hounsfield units of the intra-abdominal free fluid, which are very critical in cases of hemoperitoneum. So you see large amount of fluid in the peritoneal cavity, which is ascites, right? So, but if you come down and if you measure the Hounsfield units, which is one of the way we measure the attenuation of the contents on CT scan, is Hounsfield units. So this is 65 Hounsfield. Anything between 40 to 70 always indicates a blood within the peritoneum. So and if you try to focus more, you can see this is the iliac vessels, and anterior to iliac vessels is always your ovary. And then you can see a tiny area of blush. So in a young female, you have to think of multiple causes, and there is no history of trauma, no history of pregnancy to think of any ruptured ectopic, right? So you have to think of gynecological causes of hemoperitoneum in childbearing age. Ectopic pregnancy is ruled out in our situation because I gave you the history of pregnancy test is negative. And this is where I'm trying to draw your attention, the ruptured corpus luteal cyst. So it's very uncommon causes like uterine rupture, where there will be some intervention usually. Otherwise, idiopathic uterine ruptures are very uncommon. Endometriosis and ruptured hydrosalpinx. So the corpus luteum, the functional cyst in luteal phase, a thin-walled vascular structure, and hemorrhage may spread into the peritoneal cavity. That's what the blush, which I'm trying to show you there, is nothing but the hemorrhage can spread into the peritoneal cavity. So it has a variable clinical presentation. Always remember your basics of physiology to be a very good ED radiologist. So if you don't know the hemoperitoneum, the ruptured corpus luteal cyst as one of the causes, you may trigger an unwarranted set of investigations there. So the serum beta HCG, the corpus luteal rupture can even occur even in the presence of intrauterine pregnancy. This is one good thing to know for your exams. And the management is most likely a conservative unless the patient is going into shock. So this is one of the things which I always tell my residents. Whenever I see an ultrasound scan, I talk to them about the importance of identifying a corpus luteal cyst with the surrounding ring of fire, which is a classical picture in ultrasound images, where we can tell the clinician, hey, if the patient is having pain, it's quite common in even a physiologic cycle to have a corpus luteum and severe abdominal pain. As one of the famous quotes, which I always remember, is anatomy is to physiology as geography is to history. It describes the theater of events. So once you remember your basic physiology and anatomy, it will be a very crucial way to perform your job. So this is one thing which where I say that the basics are the foundation. If you are good with your basics, your practice, you will turn out a good practitioner. So briefly to talk about hemoperitoneum and how the radiologist helps the clinicians. Here is a classic case of hemoperitoneum where I showed you multiple areas of blood. Here, just there is some thickening of the lateral corneal fascia and dependent fluid there, but most predominantly there is an anterior abdominal fluid here, some more fluid around here. So these are some of the cases where the CT will be really helpful in a cases of hemoperitoneum to diagnose where exactly the blood is coming from. I was talking about Hounsfield units. So Hounsfield units, how they are useful in a regular day-to-day practice in trauma. So usually 30 to 75 Hounsfield units talk about the blood, but partially clotted blood will be a little bit on the higher end, like a 45 to 75 Hounsfield units. For example, I always tell my residents to talk about sentinel clot sign in your dictation, because if I talk about a sentinel clot which has a 45 to 70 Hounsfield units, the blood next to an organ, that could be the possible site of organ bleed. Even though the hemoperitoneum is so diffuse, even though you see blood around liver, around kidneys, around spleen, if you can focus on identifying a sentinel clot sign, most of the times, even though the extravasation or the contrast leak is not seen, you will still be able to identify the organ of bleed, which can be very rewarding sometimes by knowing this basic finding. A non-clotted blood, which will be far away from the organ of bleeding, it will be around 30 to 75 Hounsfield units. So that's the reason how we use our radiology physics in telling you where exactly is the bleed. And this is where the sentinel clot sign, the blood is so much hyperdense next to a laceration in the spleen. So even though hemoperitoneum is all over the abdomen, you have to tell that this could be coming from a splenic laceration. Whereas in sometimes you may be very classically observing the site of contrast extravasation into the hemoperitoneum. In that case, you can directly straight away say that there is a active contrast extravasation, because this becomes a very important finding when you're talking about your hemoperitoneum within the, especially when you're dictating a trauma case, because the rate of bleeding and presence of extravasation are the ones which are going to determine the patient's management rather than a large hemoperitoneum or a small hemoperitoneum. A large hemoperitoneum with no active contrast extravasation can still be treated conservatively. A small hemoperitoneum, whereas the patient is sinking, patient is deteriorating and entering into an hemodynamic instability, even though hemoperitoneum quantity is not large. If you see such kind of things, that's the time you give a call to the interventional radiologist. For instance, take this case. There is a moderate amount of blood here. You can see that hyperattenuating fluid mixed with a hypoattenuating fluid. But more importantly, you have to look at the active contrast extravasation, which is there in the posterior part of the pelvis. This is a ground level fall. So we didn't even expect that this case will be having a hemoperitoneum. We identified the hemoperitoneum, and giving the contrast helped a lot in identifying the location of active contrast extravasation, and immediately the case was sent to the IR folks, which is another rewarding job as a radiologist. We have a great IR team here. So the amount of time you send the case to IR depends on identifying these cases. And again, putting together your knowledge, your radiological background, and then involving the IR team, that all plays a crucial role in treating the patient. This patient was having a right internal iliac artery arteriogram here, and you can show active contrast extravasation, and it is from the posterior division from a branch of lateral sacral artery, and this was eventually treated with coil embolization. So case number 4. So I'm just keeping a track of time. Yeah, I think I'm going in the right speed right now. So this case, I expect some participation now. I'll give you the basic history again, and I'll try to talk about the findings here. So this is in 2014 July, a 34-year-old female presents with intermittent upper abdominal pain. So the history says the gallbladder was removed in 2009, and she specifically mentions the current symptoms were similar to previous gallbladder pain in 2009. But the final read was normal study because we thought this is a surgically absent gallbladder. But anybody able to see anything else from this? You know that we missed something, right? Because I said the final read said it's a normal study. So we missed something. Any of the medical students with their knowledge on or people who are aspiring to become surgeons should be knowing this. Anyway, the patient again came back to the hospital with a similar complaints in 2015. So I go back to the images one more time. Yes, I see some answers there. Yeah, very good. So Salim, you identified a stone. So what do you say now? Because I said the gallbladder is removed. So where exactly was the stone? I see some more answer there. Pretty good. I'm really enjoying the participation. We have the gallbladder. Yes, very good job. Very good job, Irene. We have the gallbladder, but I gave you the history of cholecystectomy, right? So that's a good, you guys are going in the right direction. That's what I can say. You guys are going in very right direction. So this is the 2015 where you see a gallbladder-like structure, right? You see a gallbladder-like structure. You see surgical clip there. If you can focus here, you can see the surgical clip there. And as Salim was mentioning, we see some stones there and as well as clips there. But what is this? This is a cystic duct is enhancing. Anytime you see a cystic duct enhancing on a CT scan, you have to think of cholecystitis. So putting the images together, 2014 and 2015. So we see a cystic duct enhancement there. Even the cystic duct enhancement was present even in 2014. So this is a rare case of stump cholecystitis. I see some more answer. Let me just, hey, very good. Yeah, thank you. So the history is definitely should be taken into consideration, but a radiologist should have a high clinical suspicion and should behave like a paranoid. That's one lesson which I learned because we missed this case in 2014. Patient had multiple episodes of abdominal pain. That's what she told to the clinician. Then again, in 2015, she came. So we already made like a one year delay in the diagnosis. So this is the post-cholecystectomy syndrome. Some of the people, at least 30%, will have a sort of pain, which is mostly physiologic, even after cholecystectomy. But the radiologist should be aware of a long cystic duct remnant. A remnant is defined as a long if it is more than 1 centimeter. So if it is more than 1 centimeter, there is a high chance of stump cholecystitis. So to make you understand what exactly is the background of stump cholecystitis, it is usually comes in patients with incomplete cholecystectomy, leaving behind a long cystic duct or a gallbladder remnant. So when I was reading this, the first question which came to my mind was, when this is occurring, why would they leave a stump at all? Why can't they remove it completely? So if you're thinking about that, you're thinking like me, and that's a good way to question ourselves, right? When we are reading, we have to get some questions. When somebody's talking, we have to get some questions. That's how we learn science. So then I dig a little bit deeper, and then I understood it occurs in emergency surgery. Most of the cases which end up in stump cholecystitis are the results of emergent surgery. So why emergent surgery results in stump cholecystitis? Because sometimes the patient may be so sick and the cholecystitis is so extensive, when they open, all the Calais triangle, which is the area of the cystic artery and the common bile duct and the hepatic artery region, the inflammation is so extensive that the surgeon cannot enter. So sometimes it may occur days, or sometimes it may be decades after the surgery. And most of the times it is missed because of the low index of suspicion. Patients are usually quite confident that their symptoms are similar to those that prompted their original cholecystectomy, like the case which I showed you now. And the treatment is always a definitive cholecystectomy. Now they make sure that the inflammation subsides there. Now they go there and take out completely. So the teaching point I always tell my residents is the remnant cystic duct or a gallbladder with cystic duct stump is not an uncommon cause of post-cholecystectomy syndrome. So when you are reading a CT scan of a patient with post-cholecystectomy, be aware of the stump getting re-inflamed, the high index of suspicion, and if you want to be a good radiologist, be a paranoid. The optical illusion. So this is, I leave you a couple of seconds here and tell me what exactly you are seeing. Are you looking at an old woman? And look at the focus your attention on this image here. Are you able to see an old woman there? Or are you seeing a, yes. Wow, so we got some additional information on the stump cholecystitis. The interventional radiologists are now treating this condition with ablation therapy of the residual gallbladder. That's very good to know. And yeah, so you're all seeing an old woman there, right? So let me play this video for you. So I may have to.
I think you can discard, right? Oh,
What is that?
No, I thought that it just wanted you to discard your writings and then it would play.
I just want to.
Okay.
Yeah. Yeah. Why is it not? Yeah, discard, yes. Once you discard it, okay, so now I may have to share this screen, right? Like share screen. Where is the?
Yeah.
Are you able to see the screen now?
It's about to start. Yes.
Are you able to see the YouTube video?
Yes.
You're able to see the YouTube video, right? Yeah.
Yes.
Let me play it from beginning. So let's get back to my this one. Are you're back to the presentation? Am I right?
Yes.
Okay, good. So I hope everybody saw that the optical illusion. So this is one of the traps for every radiologist, and I share one of my recent experiences here. Good eye, how you have to train your eyes despite of uh, the surrounding distractions you have. Then how it helps the clinician. And this is one of the cases, unfortunately, I missed it, but still I want to share this so that somebody learns from my mistakes. So if you look at the picture here, so this image, it gives you a dilated fluid filled enhancing bowel loops all over the abdomen. I did not see any signs of bowel obstruction because only the large bowel is abnormally distended, but the small bowel loops are normal in caliber, and they were a little bit more thickened than expected and hyperenhancing. So I gave them the diagnosis of enteritis. But unfortunately, what I missed is, oh, sorry, I did not. So let me try to draw the pictures here. So I was talking about all the bowel loops here, all the bowel loops here, all the bowel loops here. So I said this is all a case of enteritis with intra-abdominal free fluid. But what I missed is if you look at the small distended bowel loop here, that is the appendix with an appendicolith there. So this was totally missed from my eye, missed from my vision. And then the case was like treated as for enteritis, but again came back again. So luckily it did not perforate, but this is a secondary complication of severe appendicitis presenting as an enteritis. So this is how a normal appendicitis looks like: inflamed appendix loop, a little bit relatively distended with a periappendicular inflammatory stranding, but rest of the bowel loops will be normal in the fat. But in this case, because of the surrounding inflammation of the bowel loops, we totally miss that. So this is one thing which I always tell: a good eye is like meditation. So even though you found the answer, you have to keep on searching. We have one terminology in radiology called satisfaction of search. Never fall for the satisfaction of search or the happy eye syndrome. Once you find something, you think that is what is the reason for the presentation. So you have to keep on searching. And the optical illusion, which I tried to show you, is one of the reasons why you try to downplay the real cause and overplay the complication of it. So ordering studies. Next thing which I say as an important role of radiologists is get involved with the clinicians while ordering the studies, working closely with the ED colleagues. So when I say ED colleagues, it's not just about doctors. You have nurse practitioners, you have nurses, you have surgeons, you have trauma team, everybody. Use of services in ED to make sure that are we absolutely utilizing them? Are we underutilizing them, or are we overutilizing them? Limit the use of imaging, but you have to use it appropriately. And the various initiatives, like you can take Canadian clinical rules plus ACR appropriateness criteria, going through them, going through the list, and then identifying what is the right modality of investigation, what is the primary modality of investigation when you are suspecting. For example, for right upper quadrant pain, the CT may be one of the options, but why can't we start with the ultrasound when we are thinking the cholecystitis is one of the causes? So it has to be like thorough specific, follow some criteria to what exactly is the imaging modality to order and how you're going to get there. Choosing wisely campaign by American Board of Internal Medicine Foundation is another site which I would recommend all the young doctors to go through to understand the pros and cons of radiation. And ordering physicians in ED includes nurse practitioner, physician assistants. So some of them may not be completely aware of these initiatives. You have to educate them. You have to, whenever I talk to my nurse practitioner or a physician assistant, I tell to, once we had discussed the case and once we decided what exactly is going to management, I try to tell them, did you understand? This is how we did it. We could have done differently. We could have done better. In some cases of acute cholecystitis, somebody orders, even though after diagnosing a stone in CT, if they again order an ultrasound, I tell them, like, we have already diagnosed the stones. In this case, the ultrasound may not really be valid. So you have to discuss those findings with your clinicians and educate. Every communication should be taken as an opportunity to educate the clinician, as well as you get educated with the clinical presentations. Work more closely with the ED colleagues, and education plus appropriateness criteria and structure of radiological dictation. So once you discuss, you have to make your dictation in such a way that the clinician gets benefited from it. So make them more crisp, clear, and be consistent, and always include the communication in your dictations. And recommendations you're making, make that when you make a recommendation, make sure that your clinician understands the impact of the recommendation. And also keep in mind, especially in our setup, we have to see what exactly the healthcare costs of each examination, and not to burden too much people with these incidental findings, and do not cause any unnecessary apprehension in the patient. So being a good team player is also a part of radiologists. So I just want to give a brief idea of to the medical students, like, if you are thinking of radiology as your profession, it's not just about sitting in front of computers and sitting in front of technology and making a dictations. It is always, you have to inculcate the habit of when needed. You need not disturb every clinician all the time, but when you make a communication, make to see that the impact of the communication should be rewarding both to the clinician. It's not only both to the clinician as well as the radiologist. It should be the impact should be great on the outcome of the patient's management. So summary, as I told you, there are certain things which we have to derive for ourselves. If I have to summarize all the things which I discussed, time is money, and sometimes getting a radiological investigation in the right time. And if the radiologist identifies the diagnosis on the right time and communicates with the right people and alerts the surgical team, it can be beneficial to the radiologist as well as the patient. And knowledge, be thorough with your medical knowledge. Like, for example, the angioedema case, which I was trying to show you, unless you know that ACE inhibitors or some food substances can cause angioedema, you may be diagnosing it as an enteritis or an ischemia, or you may be even thinking of bowel obstruction, partial or questionable bowel obstruction. So all these things happened for an angioedema as a under call. And always be thorough with your physiology and pathology basics. Like, if you, for example, the corpus luteal hemorrhage case, it is just a physiological interperitoneal hemoperitoneum. If you know that, you can keep the patient in observation, and you have to understand the cycle in which the menstrual cycle the patient is, and then you will be able to understand the corpus luteal appearance of an ultrasound, and you can come hard on your findings. Yes, this is what I'm seeing, and this is what I believe. And the stump cholecystitis case is a good example to have high index of suspicion. Even the clinician is not suspecting it, it becomes the job of the radiologist, who is looking inside the body, to think like a paranoid and have a high index of suspicion. Take pride in having a good eye. Do not have the satisfaction of search. Always believe that for a radiologist, the image is the patient and your dictation is your image. Once your dictation goes out, the clinician will be trusting you based on your dictation. So be careful with your dictations. Be a good team player. This needs more emphasis to medical students, as well as for your USML exams. How exactly you understand the appropriateness criteria. What are the right imaging modalities to order for each situation? So, of course, the one thing which I would tell everybody is we all are evolving in this area. I work in a very higher end university. Still, we see a lot of unnecessary examinations are ordered. It's not that we are not aware of it. We are trying to balance a lot of things here. So we are trying to make an adjustments, and it is still a thing which is under process. So, but being youngsters, you can inculcate better practices. Do not go into the habits of ordering what was told, but follow the criteria, which will always do good to the medical healthcare system here or there. And understand if you become a radiologist, the key important thing which I will always tell is understand your audience. When you're talking to audience and when you're talking to the clinician, always remember that they come from different backgrounds. It's a diverse audience. Some may be a nurse, some may be a nurse practitioner, some may be a physician assistant, some may be a surgeon, some may be an ED physician. So you have to articulate your language based on that. If you talk about a bowel ischemia, your tone should be different with a surgeon, and a nurse, you should be able to tell them that I need to talk to the surgeon immediately. So you have to articulate according to your audience. So thanks for joining. That's what I have, and I think I finished absolutely on time. And then if you have any questions, we got 5 minutes.
Absolutely. Thank you so much, Dr. Maddu, for the moment of Zen. I actually feel very Zen right now, having watched this lecture. Are there any questions? We see quite a bit of thank yous coming through. You know, I will tell you though, I think the thing to take away from this lecture is the next time you have a case, whether you're going to the surgery, to the operating room, or you're in the emergency room, or you're in the ward, and there is an image, what I would encourage you as a medical student or is just to go to the radiologist, find them.
Yes.
You know, because
discussion, yes.
Yeah, so it's because if you find them, then you're actually going to get a lot of help and you're going to learn a lot, because you can see how Dr. Maru was going through, showing you the anatomy, showing you the clinical history. So that rapid processing is also very important and very emphasized in the USMLE process, because they'll give you a clinical vignette, but you should be thinking, oh, lisinopril angioedema, but you may never have seen angioedema in real life.
Exactly, yeah.
So just as a good practice for being a student or even a medical officer is to try and get out and see more cases that are, you know, in this sort of space. But are there any other questions? I just see thank yous coming in.
Yeah, as I can see that. Yeah, thank you everybody. Thanks for joining. It made my Saturday. I'm going for my weekend call in the afternoon, and before that, you made me pretty happy.
So there's a question here about the Hounsfield units. How do you calculate them?
The Hounsfield units is like a CT physics related question. So it is automated within the machine. Only thing is, the one thing which I can tell you is the measurements vary from 1,000 positive to minus 1,000 around. So for example, if you see air, it will be around minus 700 to minus 900. If you see fat, it will be minus, it's a negative Hounsfield units. So it depends on the absorption of the material of the photons which are transmitted. Like for example, in a radiograph, why the bone is white, why the lungs are dark. If you think from there, you will understand the Hounsfield units, because the bone has calcium. The air in the lung doesn't have any metal or any material which can absorb the photons passing through the body. So depending on the basic same level, like for example, why the bone is so bright, because it has calcium. When the photons are passing through, it absorbs most of the photons, whereas when the X-rays pass through the lung parenchyma, there is no way that any of the photons get absorbed. So they directly fall on the film in a case of X-ray, and in a case of CT, which uses the X-rays, it fall on the detector. So when it falls on the detector, the way the fat treats them, the way the blood treats them, the way calcium treats them, the way the lung or air treats them, and the way the soft tissue treats them, and the way iodine, the contrast treats them, is totally different. So it is a computerized calculation to give you the absorption of the X-rays. The more the X-rays are absorbed, the Hounsfield units will become more and more positive. The less they are absorbed, the well they are transmitted, the negative value comes in. That's where the fat and the air will be having a negative value, whereas the calcium and the bone will have a positive value. Blood and the soft tissues, which are around 40 to 50 Hounsfield units, they fall in this area of this blood. I said like 40 to 75. If it is a non-clotted blood, it will be like 10 Hounsfield units because it's all the plasma and serum which is coming there. So that's how the Hounsfield units are useful for us.
Okay.
Hope that is clear.
Yeah. Okay. So next week I will be giving a general lecture strategy for the exam. Not a general, specific lecture for strategy for exam focused on step 1. And I think I'm going to be focusing around the chest area. But
so I see one more question here from Serge. Yes. So my answer is, yeah, post-cholecystectomy, the thing which I want to tell you, tell everybody is it's a high level of suspicion which made the diagnosis. Otherwise, it would have been even missed second time also. It's not the CT or the ultrasound. Because if you see the Murphy sign positive while doing an ultrasound in a post-cholecystectomy, still you can suspect a post-cholecystectomy syndrome even in ultrasound. What is the difference between interventional radiology and emergency? Interventional radiology is totally where you intervene, either through vascular. Emergency radiology is like I'm just available, like I'm like any other general radiologist. Whereas interventional radiologist is either through vascular or through the non-vascular methods. They try to help in the management. I think that's what I would say.
Okay. Awesome. Okay, we'll have our final word from Dr. Newsom, who's the other person who usually joins us on this. Thank you so much, Dr. Maddu, for your time and an excellent presentation. Hopefully you will be back.
This one for all of you who are here. Now I would like to say a couple of things. The reason why I started with this lecture is to tell you that what is the scope of radiology apart from the high technological and high imaging utilization, apart from sitting in front of computers or interventional radiologists. And apart from all this, there is a different perspective where you take a case, you try to chase the answer, and in that chasing that answer, you all have some kind of satisfaction being a doctor or being a physician or being a role in the management. So I always felt one of the questions asked me for when I'm taking I have done like 3-4 different fellowships. They asked me why emergency radiologists. So I have thought about this a lot of times, and one answer which I gave to everybody is same. Like, I always felt I was in the part of the management. So it may be true for every radiologist, but one thing which I want to make an impact on the clinician, on the medical students who are aspiring to choose their fields. It is always a way to look into the job of radiology. From next time onwards, what I will focus is, I'll talk with Judy more, and I'll be coming out with the radiological description of each case and what exactly you have to learn. I will try to make like 4 or 5 lectures every year so that we will be repeating them and getting them better every time. Okay.
Thank you. Dr. Newsom, final word.
Awesome word, awesome lecture, final word. So the final word for today is called the stretch. And when I say the stretch, I mean that what people are always afraid of stretching. When I think of stretching, I think of it really is the difference between your comfort zone right now and your dreams. But this expansion is necessary to become a better version of yourself, of ourselves. And I find that the fear, people are afraid of stretching, usually because of lack of trust, this inability or just being afraid of what that next person is going to be. And so I challenge each of us this week to find a way to stretch, find someone that you can trust. be aligned and find a friend that will help you to become a better version of yourself. And as I thank you all for allowing us, as you stretch every Saturday, stretching your mind, stretching yourselves to become a better version of who you're going to be. And we appreciate it, and we don't take it for granted. That is my final word.
Okay, thank you, everyone. See you next week if you're able to join us. Welcome to the students from Rwanda. We know we have quite a number of Rwandan students in addition to our Kenyan students. Thank you, and kwaheri, jioni njema.
Thank you so much. Thanks, everybody.